The ECHELON-1 study was a large open-label clinical trial, and basically it compared two arms. One arm with brentuximab and AVD versus ABVD, which is the standard of care until now, for example. So, and this trial was basically for advanced stage Hodgkin lymphoma. And what we see from this update data, this 5-year PFS, it was a consistent superiority over ABVD. So A plus AVD or brentuximab plus AVD still showed a large superiority independent of any risk factors like IPS risk factors or stage disease 3 or 4. And mainly, I mean, what is very interesting for me is it is independent of the interim PET. Although interim PET was done for all patients in both arms, but this superiority was independent of this interim PET. Basically, the number that you see, the difference between these two arms when you talk about PFS per investigator was around 7%, which is a little bit higher from the 2-year release that they released about 3 years ago, and which shows that the introduction of this new drug sustained a very good response with, I say that, with a very manageable safety profile. If you compare the 2-year data with the 5-year data, what we see is basically a 30%, 31% reduction of death and progression due to ABVD when you compare A plus AVD versus ABVD. Okay, usually we all know that Hodgkin lymphoma is a highly curable disease, but the curability is really related to stage. If you talk about stage 1 and 2, you are able to cure about 90 to 95%. If you talk about stage 3 and 4, there is an unmet need because we see a higher rate of relapse, around 25 to 30%. So with this study, they really point like a light in the end of the tunnel that it's possible to decrease the relapse rate. And if I say so, I can easily say increasing curing rate by adding adcetris to AVD. So this analysis was done around 5 years, exactly 55.6 months. And when you talk about relapse rate, you see at least 31% decrease, which is great because you are talking basically about young patients who are, who we really have to cure them and to send them back to work, to university, and to marriage, etc. So it's really something that gives me pleasure to say about this data because it's really groundbreaking. And when you see this maintenance of response, it really ratifies, it shows that the brentuximab with AVD is really a valuable option for this kind of advanced stage patients. Interesting, in this data that we are going to see in the ASH meeting, they also compared pregnancy, and there was no difference between pregnancy in both male and female patients between these two arms. So we didn't have much doubt about it, but it's good when you see this data comparing these very good phase 3 trials, showing that there was no difference in pregnancy and any, birth defects. So highlighting this safety of adcetris plus AVD versus ABVD. the first paper released about 3 years ago used a modified PFS, which means that it's basically the modified PFS is the progression. I mean, when you stop, I mean, the stop is due to progression, death, and basically the receipt of any additional therapy for patients not in CR. What does it mean? You take out radiotherapy as a consolidation therapy just to focus basically on the real benefit of the addition of brentuximab to this protocol. But the next release, 3 years, 4 years, and now the 5-year release PFS, it's not a modified anymore. It's just by investigator, which take this idea of radiotherapy or any additional therapy from our analysis. And I can say that this is an exploratory analysis, post-hoc analysis, but it still shows a great advantage of adding this new drug to the standard of care. And together we were also able to take out bleomycin from this protocol. And we all know that bleomycin is very toxic, both for young patients and mainly for old patients. So it's good because we see a consistent superiority, and you were able to take bleomycin from this treatment protocol. And another thing that I want to emphasize, and I just said it before, but it's good to highlight that, because there are very types of treatment guided with interim PET. So if you have an interim PET positive, you can escalonate therapy. And this, of course, can bring more cure, but also can bring more toxicity and side effects, etc. Mainly sterilization, acute, secondary, late and early and late onset to toxicity and neoplasia. But with this protocol, the addition of brentuximab with AVD, there is no need to escalate therapy when the patient has an interim PET positive. And of course, that we are not able statistically to compare every studies that use this escalation based on interim PET. But if you look just with the numbers, we can easily say that there is no need to escalate therapy. And this means increase the chance of side effects when you use this protocol. So I know that I just said it before, but it's good to emphasize that this protocol is still show a highly efficacy versus ABVD independent of the interim PET. Yes, I mean, for the last 10 years, what we are trying to find is a chemical protocol that's at least as efficient as ABVD and or less toxic than BCOP. So I think that the future, mainly for this stage 3 and 4 patients, is very, how can I say, is hopeful, because we are not adding more toxicity, but we are adding more efficacy. But I must say that the addition of brentuximab with AVD, of course, there is a higher rate of neuropathy, but with this extended follow-up data from 3, 4, and 5 years, told us and showed us is that at least 85 to 86% of all patients in both arms, because we must remember that ABVD also had neuropathy, mainly due to vinblastine. But what we can say is that around 85% of all patients had this neuropathy resolved. So although it's not a non-side effect protocol, but it's really manageable. And of course, when you talk about the younger patients that are looking forward to start working again and have their life back, of course that it's just a small side effect comparing to the higher response rate that this group had.